Okay, well, I know people are still joining, but my name's David Davis. I'm the chairman of the Red Line Group, and it's my absolute pleasure and delight to introduce Professor John Nicholls in a short while to talk to us about his reflections on his 40 years of working at St Mark's, and in particular on the pouch surgery. It's the latest in our series, so thanks to Christopher Brown, who's helped set up the speakers, and also to the technical guru, Gary Bronzier, who is pressing the buttons and has set up the Zoom facility. Thank you both. Before we start on the, before I hand over to Professor Nicholls, I just wanted to go through a little bit of administration for anyone who hasn't used the Zoom facility before. So what you can see on the screen there is a simple admin representation. If you wiggle your pointer on the screen at any time during the presentation, the black bar there that you see towards the bottom comes up. And if you click on the chat function right in the middle of the screen, in the middle of the black bar, it'll open up the Zoom chat window where you'll be able to type in any questions or comments that you'd like me to put to Professor Nicholls. Ideally, we'll leave the questions to the end, ideally, just for the sake of timekeeping. But rest assured, if you press type in your questions, press return, the questions will come through. So that's how you ask questions. I'll see the questions as they come through and be able to sort of hopefully organise them into some sort of broad order for Professor Nicholls to answer at the end of his presentation. Thanks very much, Gareth. So Professor John Nicholls, now I suspect there'll be an awful lot of people here who have a very personal reflections on their experiences with you, Professor Nicholls. So I'm delighted to facilitate this Zoom event to allow them to hear you again talk about your reflections on the surgery. You have a prolific and long CV, which I was looking at last night, but I won't go through it all, but suffice to say, your eminent and a fabulous history serves you great credit and gives you great credit, and has been fabulous for all of us who've benefited so much from pouch surgery over the years. I understand you were a consultant surgeon at St Mark's since 1978, working with the great Sir Alan Parkes on developing the pouch, and I'm sure many other initiatives as well. And in fact, 1978 was the year that you published a seminal work on pouch surgery in the British Medical Journal. And that must have been a great moment for you in your career, and obviously the springboard to many great things. It's quite amazing, actually. The Marquis Who's Who describes you as a noteworthy surgeon, which is obviously quite a feather in your cap. And I note also that you were born in Wilby, which is a tiny village in Northamptonshire. I always thought you were Yorkshireman for some reason. I don't know why, but my apologies for that. I could go on. You've obviously got years of experience of pouch surgery, and you've got a great audience here today. You've got represented people from Red Line Group. You've also got people from the Kangaroo Club in Oxford. You may also have people from the J Pouch UK specific Facebook group, all of whom have been invited. And there may be others, of course. So we're all delighted to have you here today. And without further ado, I'll hand over to you for your presentation. Thank you. You're on mute. John?
He is. Okay. Should be unmuted.
Myself.
We can hear you. Okay.
No, unmuted. Well, first of all, thank you, Chris, for inviting me, and David, thank you for your very kind words. And Gary, it's been lovely to talk to you yesterday. You just made it secure that I can work the share screen function, which is actually so extremely easy. But no, thank you very much for that. And it's a great pleasure to, out of retirement, to look back on things that I've long not forgotten, but left behind. Because I retired from the NHS in 2006, having served about 30-something years as at St. Mark's. Perhaps I just need to do the arithmetic on that. Since then, sort of maintained an interest, of course, in research and teaching, and diminishing clinical practice. I never really did very much private practice after I retired, perhaps for a year or two. But I've retained contacts with our colleagues and made new friends through continuing to attend the National Meeting Association Coloproctology of Great Britain and Ireland, and also the European Society of Coloproctology and the American Society for Colon and Rectal Surgeons. So I sort of remained in the area I know about, and it's been interesting to see how it's developed since. This is, in a way, this is a history. I'm just going to go to the share screen, share, and I'll just get myself, just matter of getting the space to do it. There we go. Right. So this is a history. It's not an up-to-date account of what's happening today, although many, many changes have occurred, as we all know. So this is a history, and it's not an up-to-date account, but an awful lot has happened over the years since I became a consultant in 1978 at St. Mark's. And when I started, in clinical practice, there was hardly any useful form of investigation that had any accuracy. All we had at the time was just barium contrast X-rays, which were liable to false negative and false positive results. And it wasn't until these things came in that doctors in general were able to precisely to not only identify disease, but also to assess the extent and severity of it. And it's a wonderful thing how imaging of the large bowel, either by looking directly or through X-rays or through magnetic fields in which molecules are forced into an alignment by a big magnetic field, which is then suddenly switched off, and they all flick back into their natural position. And the rate at which they do so is different in fat, in muscle, in various different tissues, and also in tumors compared with normal tissue. So there's extraordinary developments that have occurred that combined with these very, very important aspects of modern data collection through the US National Library of Medicine. Sounds a bit dry, but what this is a fantastic project lasting decades now, in which all publications in all the scientific journals, medical, but also other forms of science throughout the world, are identified and logged by this organization, the US National Library of Medicine, in such a way that any ordinary practitioner or academic in a university department or whatever, provided they have the link, can download these original articles and in an inexhaustible way. So it's a fantastic development. And of course, with the internet, which of course is required for access to the National Library of Medicine, but in other forms of study, combined then with evidence-based medicine and all these other things. This has occurred through not only my lifetime as a surgeon, but also your lifetime to some considerable extent, as we all are members of the public, and we've been in an extraordinary era of scientific advance. But just to go then to the history of the pouch, which really starts with the identification of the disease ulcerative colitis. Is the pointer visible as I use it?
Yes, yeah, I can see it.
Yeah. Okay, thank you. In the late 19th century, up to the end of it, most cases of serious diarrhea, many of which were fatal, were the result of infection. And it wasn't until the introduction of, or the discovery of bacteria, combined with astute clinical observation, that a group of patients who had diarrhea did not have diarrhea due to a bacterial cause. And the pathologist Nothnagel in Vienna identified or demonstrated that an infective colitis always had evidence of pus under the internal skin, and Hale-White observed that in a certain number of patients, this was not present. And these were grouped as patients with the new disease of ulcerative colitis. And over the next sort of 20 years or so, a certain amount of experience was obtained in treating ulcerative colitis. And you can see here a very interesting publication, 1909, in the Journal of the Royal Society of Proceedings of the Royal Society of Medicine, when they held a symposium on ulcerative colitis in 1909. And you can see there that the mortality of this disease, often, as we all know, affecting young patients, was very high indeed as time, as the disease progressed over some years. So this was a serious condition that affected young people. And over the subsequent 40 years or so, there were numerous remedies attempted for various forms of irrigation of the colon, giving an ileostomy to patients in hopefully to defunction it so that the lining of the colon, the mucous membrane, was rested, and so on. But none of these were effective, and the mortality remained extremely high. For example, in 1930, if you were suffering from ulcerative colitis so severely that the surgeons at the time, thought that you should have an ileostomy, nothing more. They were worried about extensive surgery in any case, that your mortality just from the operation itself was approaching about 50%. And then in the late 1940s, a group in Montreal, Miller and colleagues, reported 20 patients with severe ulcerative colitis where they were so severely ill that clearly they were going downhill towards death quite quickly, that the patients were dying to a considerable extent through serious protein losses in the feces, owing to all the nasty inflammatory exudate produced by the disease in the colon. And they said, well, it's all very well giving an ileostomy, but why don't we just take that organ out? And they did that, and suddenly the mortality of, as I put 30% plus, it's a very high mortality, of course, for the disease, fell to something like 5% with the passage of time. And shortly after that event, which of course required an ileostomy, which was a very difficult thing to manage. Here you see one such appliance. Professor Brian Brooke, who was professor of surgery at St. George's Hospital in London, having come down from Birmingham, where he was a senior lecturer, devised this everted ileostomy, which made life with an ileostomy very much easier. And it effectively meant that the operation of proctocolectomy, which involved removing all the colon and the anus, rectum and anus, was something that people could live with and manage. And more or less simultaneously, steroids came in, originally applied to arthritis, but very shortly afterwards to inflammatory bowel disease. And Dr. Truelove from Oxford was a major world figure in the analysis and devising of medical treatment regimes for people with ulcerative colitis of different degrees of severity, which he was able to define, and demonstrated that corticosteroids were beneficial, particularly in the acute phase of the disease. So by the end of the 1950s, coming up to 1960, the general view about of the management of chronic ulcerative colitis was that total removal of all the affected tissue was the correct procedure when surgery became necessary. It had a low mortality. It removed all the risk of cancer, which of course does occur in patients with inflammatory bowel disease over many years. To remove it removes that cancer risk. And there was a high patient satisfaction, partly because they were able to manage the ileostomy reasonably well, but mainly, of course, by virtue of the fact that the operation gave them back their general health, and they felt they were effectively cured from the inflammatory process. But of course, the ileostomy presented some difficulty, of course, and surgeons had worked in various ways to try and avoid an ileostomy. And Stanley Aylett, who worked at the Gordon Hospital in London, now in Vauxhall Bridge Road, no longer an acute hospital, was a great proponent of removing the colon and joining the small bowel to the rectum, preserving therefore the anus and thus preserving anal function. And here are some results of his series of patients published in the early 60s. And you can see a low mortality surgery at that time and a high proportion of patients returning to work. But the operation had its disadvantages. Owing to the persisting rectum with its inflammation, often the function was poor due to urgency and frequency of defecation. And this was a very significant difficulty, and some of you in the audience may have experienced the sort of frequency and particularly urgency that occurs in patients with inflammation of the rectum in inflammatory bowel disease. And there was also a long-standing risk of rectal cancer, which, as you can see, rises as time goes on, from a modest figure at 20 years in his series, going up to a less modest figure 10 years later. So owing to these risks, other means of trying to avoid an ileostomy were tried. And this was really the seminal paper published in 1947, which set up the whole area of total removal of the colon, the rectum, and the part of the anal canal, the upper part of the anal mucosa, leaving the sphincter muscle behind, which resulted in total removal of a disease limited to the large bowel, limited thus to the colon, rectum, and anus, which could then be treated by total removal and an anastomosis or surgical join between the small bowel above and the anus below. You can see on the left here a photograph of Rudolf Nissen, who was a German surgeon in Berlin in the late 20s and the 30s. He fled Germany to go and work in Istanbul for a while, when the Nazi regime came into power in 1933. And he ended his career in the United States, having made many interesting and important contributions to surgery, including surgery for hiatus hernia. So he published a case report in 1932 of exactly this operation. And Mark Ravitch and David Sabiston. Ravitch became president of the American Society of Surgery. I had the privilege of meeting him once when he was quite old. He was a very courteous and delightful person to meet and have dinner with, which is what happened on that occasion. But I subsequently learned that when he was younger, and if you were a resident on his service, you had to work pretty hard, and there were there was no there were no prisoners taken in your performance. You were really in the hands of under the supervision of a quite a tough person. But he was obviously mollified with age. And David Saveston, who wrote a very extensive textbook of surgery, published a case report of 2 cases with polyposis as it happened, who underwent a total removal of the large bowel with an anastomosis between the small bowel and the anus. And these patients did reasonably well, according to the article, which was published in the Annals of Surgery, in terms of function. But it became clear, as a few more patients, now some with ulcerative colitis, had this operation, that, if you see there at the bottom, so-called straight ileoanal anastomosis was very frequently associated with urgency and frequency of defecation, which actually made life very, very difficult, if not impossible, for some of those patients. Going urgently 10 to 20 times for 24 hours, as many people here will know, is a very difficult and almost impossible situation to manage. And Harry Bacon reviewed in a paper in 1955 these cases, identified the fact that an awful lot of them had very poor function, and suggested the possibility that putting a reservoir into the system might improve the function, which is what he did in dogs here. And you can see a sort of pouch down there that he constructed out of the last few centimeters of the small intestine in the dogs. But unfortunately for the dogs, the mortality was very high. And this idea, although logical, was not taken up particularly, if at all, by surgeons generally, owing to the risks of the surgical risks of the procedure. So the next item of importance in the history of the development of the pouch was the work of Niels Koch from Gothenburg in Sweden, who originally was trying to devise a means of creating a near bladder for people who had to have their bladder removed, usually for cancer. And in the development of this operation, he realized that making a reservoir out of the small intestine could also be applied to patients who required a permanent ileostomy. And the result of his work became much more useful and valuable in treatment of inflammatory bowel disease than it did for any urological urinary condition. The development of the Koch reservoir, which came out on the front of the abdomen with a flat stoma and had an internal construction in such a way that a valve was formed to render the whole pouch continent, could be then emptied by the patient putting a catheter down through the ileostomy, breaking the seal, as it were, of this little inverted valve that had been created, and drain off the feces into a dish or straight into the lavatory, and thus have a system where an ileostomy was present, but it was effectively a continent ileostomy. And on average, with surgeons taking this operation up across the world, probably something of the order of 60% or so of patients had a really good result, but quite a number did not, in that this valve mechanism often gave way, and many of them required further surgery to re-establish the internal valve, and one could say that overall, in those patients, they had continuing difficulty in many instances. But Koch himself published results towards the end of his clinical career where his reoperation rate was only of the order of about 50%. And indeed, the cock ileostomy operation is now coming back into vogue in patients who have had a failed ileo-anal anastomosis. And that's something perhaps you might wish to consider in the discussion. So having developed the idea of removing all the inflammatory disease, preserving the anal sphincter, and adding in a reservoir, Alan Parks devised what was called in that paper of 1978, which David was referring to, proctocolectomy without ileostomy for ulcerative colitis. And I was immensely lucky to be involved in that study and report, being, as I was at the time, Alan Parks' senior registrar. And it was a very piece of good fortune for my own career, but also it helped to me personally to be involved then in the subsequent development of the operation. Just to go to St. Mark's Hospital for one or two slides, because they're relevant to Alan Parks. St. Mark's Hospital was founded, as you can see there, in 1835 by Frederick Salmon in Aldersgate. It's no longer present, although there is a site where it was, for which there is a blue plaque just opposite London Wall, which they never put up, but the plaque is made, and we had it photographed with Archbishop Runcie and James Thompson and myself in the picture, so there's evidence that there is a plaque. But as the demand for treatment increased over the years, it had to move to a bigger place, and in 1852, it moved to the City Road within the parish of St. Mark, up in Islington there, at the top by the Angel, in St. Mark's Square, and called itself St. Mark's Hospital. This is the old building here, and in the 20s, a sizable enlargement and expansion was undertaken, and that is how it was when it was sold in the early 1990s, and it became St. Mark's Apartments. And I understand that in the last year or two, the building has been further sold, but I'm not quite sure what its current function is. But that is St. Mark's Hospital, which over the years developed diseases of the anus and colon and rectum. Other than Moorfields, when it was founded, it was the only other specialist hospital, certainly in London. And as a result of this, it was looked down upon by all the big general hospitals. They thought that specialization was an inferior pastime to being a great generalist. But the effect of being a specialist hospital is that over the decades, St. Mark's really did lead the field worldwide in the understanding of various forms of disease affecting those organs and the management of them, initially mostly through surgical approaches, but more recently through medical treatment. So this was a great tradition which still lives on in St. Mark's having moved to the Northwick Park site, and it has continued to be among the leaders in the field of colorectal disease and coloproctology, as it's called. And I put this photograph up because this is the occasion of Mr. Gabriel, William Gabriel's last operating list, 1962. And there are some very great figures around the table, around in the photograph, which if you're not a surgeon, perhaps don't mean a huge amount. But here was Naunton Morgan, who was the first, with Lloyd Davis, who devised, not quite, but in simultaneously with Kirchner in Germany, the total removal of the rectum for cancer, in which two surgeons working simultaneously. Here was Milligan and Morgan, who wrote up the first hemorrhoidectomy that is now adopted worldwide. Here is Cuthbert Dukes, who was the pathologist, who was the very first person to devise staging systems for pathological staging systems for cancer. He did it for the rectum and he did it for the bladder. Here is his subsequent, his follower, Basil Mawson, who was a very great figure in pathology, who identified the risk of cancer in ulcerative colitis, and that one can predict cancer, the development of cancer, looking at the microscopic picture of biopsies taken from the rectum. Was the first indication of preventative approach for people with long-standing ulcerative colitis. Here is Ian Todd, who became president of the Royal College of Surgeons, Lockhart Mummery, who was the Queen's surgeon, Henry Thompson, who was a very great surgeon indeed. One or two stories about him, which I haven't got time. I hope I'm not going on too long anyway. And here's Gallagher, who was appointed in 1946, who went to Leeds as professor of surgery in the early 50s. Nobody would talk to him. None of the surgeons up there wanted to know this person. So he sat and wrote a textbook, which is now an absolute classic worldwide in the field, and he became a very famous and well-known surgeon. And here is Alan Parkes, who followed Gabriel, despite Gabriel's determination that Alan Parkes should not be his successor. And the reason for the determination was Alan Parkes believed in trying to avoid stomas like colostomies and ileostomies, whereas Gabriel believed that if you tried to join up somebody with a rectal carcinoma, you were conducting an immoral operation. But Parkes was appointed, and Parkes died young at the age of 61, 1982, to everybody's surprise. He had made immense contributions to not only to surgery, but also to many other aspects of medicine, including, for example, the pathophysiology of fecal incontinence, where he demonstrated with others that this was due to neuronal or nerve muscular weakness of the pelvic floor, and created a whole new study of pathological, pathophysiological investigation in a very important field indeed. And he became president of the Royal College of Surgeons of England for 2 years. He would have gone on for another year, but unfortunately he died of a myocardial or following cardiac surgery, having collapsed in Rome at a meeting with an acute heart attack, and ultimately came back to this country and unfortunately died during the surgery, trying to open up his coronary arteries. And we were all very shocked indeed. It was a Wednesday, I remember, or at least I heard about, perhaps it was Tuesday, but I came in to do my operating on the Wednesday at St. Mark's to hear that he died in the night, which was a great shock. But his name still is known even among young people today at international meetings. He's looked upon with great respect and admiration for all that he did. So in the, David, is this all right? Am I going on too long at the moment?
This is fine. I think, I mean, I'm fascinated by their history, and I'm sure many others listening are. I think you're coming on to perhaps the more relevant for the audience.
Okay. Thank you.
And it would be lovely if at some stage you could talk a little bit about the patients that you've seen, and some reflections perhaps on your experiences with the patients, but that's possibly coming a little later.
Well, I try, and I'm aware that this is an hour's. I'm a little behind, unfortunately.
That's all right. That's all right. You know, we have some time at the end. Most of these Zoom events have gone on a little bit with questions, so don't worry about that.
Okay, because not seeing an audience makes a difference, I have to say. Anyway, these were the results in the first 5 patients reported in that paper, and you can see that there were a certain number of complications and 1 failure in the sense of removal of the pouch at 2 months. And you can also see that the mode of evacuation was artificial in quite a proportion of patients, and a high proportion of patients. And this was subsequently in which, in order to evacuate, as a bit with the cock ileostomy, the patient needed to insert a catheter through the anus into the pouch in order to drain off the feces within it. This was a difficulty and a disadvantage of the procedure. And it was persisting when a year or so later, further patients were reported in the literature. About 50% of patients required a catheter to evacuate. But this follow-up demonstrated that with the passage of time over several months from the operation, on the whole, the frequency of defecation fell. You can see here that one's talking about a mean frequency of defecation of around 4 or 5 times per 24 hours. So this was something that patients were very much able to accept. When it came to the question of catheterization in order to empty the pouch, the original design of pouch that Parkes used was the so-called S pouch, in which a small segment of ordinary small bowel projected from the bottom of the pouch, and that was used to join the intestine up by sewing it to the anal canal at the level of the sphincter. And it was that little segment of ileal small intestine that was physically preventing evacuation. And once that was no longer part of the design of the operation, as for example was the case with the J pouch, which Professor Utsunomiya from Japan reported in 1980. This form of pouch did not have, as you can see here, any little projection of small intestine. It was just the pouch directly joined to the anal canal. And with few exceptions, these patients were able to defecate spontaneously. And so the original difficulty of evacuation requiring catheterization was largely overcome. And then in the late 80s and early 90s, large series from the United States, where the Mayo Clinic is hugely geared to large numbers of patients. Something like, let's get this right, several operating theaters, something like 20 or so in the town of Rochester in Minnesota, where there's a Catholic hospital and a Protestant hospital, and between the two of them, they start surgery at about 7 or 8 in the morning, finish at 4, and get through an enormous amount of work. So they can build up huge numbers quickly, which of course is of value when judging the results of surgery. And here you see complications. SBO means small bowel obstruction. That seems to have diminished in its significance in more recent years. A very low mortality, a failure rate of about 6%. Failure means the need to re-establish an ileostomy in somebody who's had anal function. And bowel movements per 24 hours, average 7 continents, not bad, and a few cases of pouchitis. And similarly, the Cleveland Clinic, who also rivals of the Mayo and the other North American clinics, able to mobilize and publish large numbers of patients in a relatively short time, obtain very similar results to those in the Mayo Clinic. But I put this up because I think this is an important paper. It expressed the total experience of St. Mark's Hospital over a 10-year period with the pouch procedure by virtue of the way our population and the way that referrals take place in the United Kingdom. The numbers were nothing like as large, but we were able to demonstrate 10-year results with a follow-up of nearly 100 months in these patients. And you can see very similar results when it comes to frequency of going to the loo. Night evacuation, I looked upon this as being particularly important. If you didn't need to get up at night, it was advantageous. That's why I introduced the W reservoir to try and increase the capacity in order that frequency of defecation should be reduced, and continence results, which again are much it's very similar to the American results. But this paper was able also to identify the rate of failure, that is to say, conversion from an anal functioning ileoanal anastomosis construction to that of an ileostomy again. And you can see that over the years, this is a 10-year period, that the failure rate is approaching 15% in this group of patients, the first 10 years of our experience. So by this time, there were several clear things with regard to the indications that the operation should be applied to patients with ulcerative colitis who had just chronic disease without severe acute component. And those who did have a severe acute component should have an initial colectomy, then to be followed, if should the patient so wish, by a pouch procedure. Crohn's disease had a very high, when treated by pouch, very high failure rate with complications. And where you weren't sure whether it's ulcerative colitis or Crohn's, then if you had no anal or small bowel disease, the chances are that you would have a successful pouch operation with long-term results similar to those of ulcerative colitis. And then if you had evidence of chronic liver disease, unadvisable to offer the patient a pouch. And in recent years, it's clear that that pouch surgery reduces female fertility, although it may be that laparoscopic surgery causing less trauma does not affect it so much. But this is something that I always took care to say to female patients of childbearing age, that there was a reduction of fertility and that they could have the option, although not very many of them took it, to have an initial colectomy to get better from the disease, then to be followed by a pouch after they'd had children. But that is something that I think is very important to that patients should know. So by the mid-1990s, we got a certain number of studies combining to allow a proper picture of what the operation could and could not do. And you can see low mortality, quite a significant complication rate, various problems, particularly sepsis in the pelvis was one of the complications that could lead to failure. And then that most patients were happy with the function they got, not everybody. But case selection was important and proper discussion with the patient, vital. And then in the surgical world, There were technical controversies, how you did the surgical join, whether or not you did do an ileostomy, and so on. And pouchitis was beginning to be studied, and I think as a, sorry, I keep flicking ahead, as a condition. I mean, it'd be interesting to hear what you feel, but whenever I tried to do research into pouchitis, it was always difficult finding patients in sufficient numbers to allow statistical analysis of the results. So it seemed not as, well, it was not as prevalent as one might think, or patients might be told by gastroenterologists. So, David, I'm just sort of winding up with a few important reflections on what else has happened in the management of inflammatory bowel disease. And the first thing to say is that there's a focus, and this goes back quite a long time now, in 10 years or so, but there's a focus on specialization or specialist large bowel, inflammatory bowel disease units, where it is hoped, and I think now it's demonstrated, that the results of management through gastroenterologists, surgeons, pathologists, specialist nurses, and so on, all working together, are better than where you have patients treated by surgeons who do only occasional pouch work. And within that context, we at St. Mark's were the first to develop pouch support nursing, and that has grown where most units carrying out any amount of inflammatory bowel disease work will have an IBD nurse, and many of them will have a pouch support nurse as well. And this is Zara, of course, whom many of you will know, and she's made a great contribution with her writing of books and so on the subject, and has helped numerous patients by giving them, with her colleagues, wise advice from experience. And then the inflammatory bowel disease unit with the multidisciplinary team meeting has become a regular feature of all inflammatory bowel disease units throughout the country, I imagine, but also throughout the world. And you see here the bringing together of specialists of various sorts can improve decision-taking and management, and indeed follow-up and promote research, and is an ideal forum for training and teaching. And then pouch support groups, and I put this photograph or this slide up at a meeting in Vienna about 2 years ago now, when I was invited over there to talk about ulcerative colitis or inflammatory bowel disease being a medium or a disease group where physicians and surgeons can work together and learn from each other. And I put this slide up to show what patient support groups could do. There are, of course, many of them, and in many different fields of disease. But the Red Line Group has been a remarkable creation and has retained its freshness and its recruitment, it seems to me, over a very long period of time. So patient support groups have occurred and made a difference. And then we started a national database in the United Kingdom, collected something like over 5,000 patients. This is I think the only national database in the world. It's actually now been suspended about 2 years ago, which I think in no position to do anything about, having been long retired up to that point. But it did demonstrate some important things, like, well, I don't know how, a low failure rate, but these last 2 or 3 observations. Low volume surgeons have not so good results. And indeed, we know that in the United Kingdom, the average number of pouches per surgeon per year was very few. I mean, that's, to me, was one sort of new, that was a fact for quite a few years. And quarter of all surgeons were only doing one pouch per 5-year period, as it were. And these were thoroughly unsatisfactory figures, which I think have been improved by the creation of the specialist units in such a way that now standards and collaborations within the management of patients by different specialists has improved considerably. So 2 years ago, we had the 40th anniversary of the pouch introduction of the pouch operation in 1978, and these were the conclusions, which I really repeat what I've said to you early on in this lecture. But most patients have a good quality of life, but there is a long-term failure rate that is significant. That the introduction of minimally invasive surgery, I think, has transformed the ease or reduced the difficulties for the patient very considerably. And the mortality remains very low, thank goodness. So that overall, the results of the operation in the long term, even after 40 years, stand up to be, I would say, very successful. And although not entirely perfect at 100%, but successful in as much as this is currently the main approach that will result in successful avoidance of an ileostomy in patients who need surgery for ulcerative colitis. And the last slide is just some people of historical significance whom I know well, except I never met Ostomy, but Zane Cohen from Toronto is extremely wise man. And I went to his retirement party about 3 years ago, which was a very nice occasion. Roger Doswald from the Mayo, Vic Fazio, who died about 3 or 4 years ago, from the Cleveland. My old friend Stan Goldberg, who's still going really strong in his 80s, traveling all over the world lecturing with Sonomia. Roland Park, who is worked in Paris and is now retired in Normandy, rides a lot of horse, rides a lot. And Les Fontaine, whom I know is well because we correspond by email. We have during this lockdown. He lives in Gothenburg. David Rothenberger from Minneapolis. Mike Keithley, whom many of you will know. That's myself there. My friend Paris Tekis and my friend Neil Mortensen, who 2 or 3 months ago was elected as the next president of the Royal College of Surgeons of England. So those are some of the people who contributed to this history of the pouch. Thank you very much.
That's absolutely fantastic, John. Thank you very much indeed. On Zoom events, for those who don't know, the way we show our appreciation is to wave our hands in the air. That's a sort of a proxy for applause. So if we could all do that, well, if you want to do that, of course you don't have to. Thank you very much indeed, John. You don't have to. That was a fantastic summary, real reflections on the history and your involvement in pouch surgery. We do have a whole host of questions, as you would expect. And I'd like to offer the opportunity to extend this event beyond the 1 hour so that we can explore some of these questions with you, if you're comfortable with that, if you're happy with that.
Yes, are you asking me, David?
Yeah, I mean, it's for everybody as well, but I just want to be sure, since you're going to be answering the questions, that you're available for a half an hour or so.
Yeah, well, now we've got, Stel, I think we've got something at 12 o'clock. One of our...
That's all right.
Maybe it's the sorry, hold on a minute. What's
That's all right.
Mary's thing? 12:30. Oh, 12:30. No, I'm okay till about 12:15.
That's great. But always wise to check with the boss. So we've got some questions. So with your indulgence, I'll run through some of the questions. To everyone, thank you for submitting your questions, and please
do my best.
do so. We'll get through as many as we can. But please, my apologies if we don't manage to get through all the questions today. But a couple of liveners to start, John. So first of all, we're delighted to have Janindra Warisavitani join us as a patron of the charity. And you are also a patron. We're delighted to have you both, of course, as patrons. One question, provocative, of course. We can edit this out from the video. But what do you think of Janindra's technique?
Well, first of all, Janindra came on the staff after I retired.
Right, okay. That's the caveat then.
What? Well, I mean, I know Janindra quite well, and I've seen him at international meetings, and indeed have encouraged and supported him to get involved. And he has a bearing and a presence, and indeed an ability to talk in a logical, sensible way that I have admired considerably. And I think he's been a great addition to the staff of St. Mark's. And I have no doubt, I mean, he's lent me slides of procedures that he's done and so on. I've no doubt that his technique is very good. It is a modern technique. So, for example, whereas I was really before the age era of laparoscopic surgery, he is not only now in it, but he's contributing to it. He's been particularly active in the field of a new approach to an ileoanal anastomosis or a coloanal anastomosis, using laparoscopic means of going up the anus going up through the anus into the rectum and dissecting the rectum out, and then bringing the bowel down from above and making a stapled anastomosis. And I sort of joke with the people who do all this as change occurs, and nothing's reversible really, that if they want to, I'd be happy to show them how to do an ordinary hand sutured anastomosis anytime they like, because it's cheaper and it's quicker. But that's never going to, once something new happens, unless it's not going to work out, which we don't know quite with this technique, but there's usually no going back. And Janindra has been an advocate of that. He set up a international registry with others, so they're looking at this very responsibly. And I have great admiration for Janindra, as I do for all the young surgeons at St. Mark's whom I never knew as colleagues, because they are appointed since
That's great. That's great. Thank you very much. So the next question, thank you. Couple of questions about why the pouch surgery is not appropriate for, let me get this right, primary sclerosing.
Well, I think primary, is there anyone in the audience with sclerosing cholangitis?
Well, there are two questions have come in.
Is that Claire? Did you say Claire?
Claire.
Yeah.
Let's see. Can't find the other one right now. Sorry about that.
But sclerosing cholangitis, or PSC, is an uncommon disease, and it's a very uncommon conflict or association of ulcerative colitis. But it's important to identify because statistically speaking, on small numbers of patients reported in the literature, admittedly, but statistically speaking, such patients have a higher chance of pouchitis, and they also have not quite as good function as people who do not have primary sclerosing cholangitis. So I think my view on that as a practitioner, David, was to say to the patient, well, look, you have PSC. and you are more likely to have pouchitis and not perhaps as good function. You should know that. But if you know, but you know, it's something that is really part of the patient's decision rather than the surgeon's necessarily. Although,
yeah,
I never quite liked. Well, I don't think I feel comfortable with the sort of thing that can happen today, where the doctor says you've got X, Y, and Z, all these possibilities, and the patient says, "Well, you know, which one do you advise?" You say, "Oh, no, you choose." And I think that's not very helpful for patients, actually. But in the case of sclerosing cholangitis, you can't say don't have it. You know, I wouldn't recommend it, because patients with sclerosing cholangitis do okay. So
okay, that's great. Another, I guess, surgical question really from a couple of people is a number of pouches fail. We know that I think it's about 10 or 11% fail and have to be resected. There's two questions here. I didn't know this was a thing, but apparently where let me see the question. A permanent eyelid, hold on, let me get the right one. In the long term, if you reverted back to a stoma and left the pouch in place, are there any risks associated to this? There's been a couple of questions around this.
No, I think that's a good question, a very good question, because it does occur from time to time. And we indeed published a small series of about 10 patients who had to have an ileostomy because of their poor function. I think usually because they had pouchitis in the pouch, which made their function poor. But the pouch was left behind because taking a pouch out is quite a big undertaking. So the idea was to relieve their symptom with an ileostomy and then but minimize the surgical trauma. And we followed, or we reported on these patients over a period of quite a number of years, and none of them had developed anything like a cancer or severe dysplasia in the pouch, which I mean was reassuring, albeit mildly surprising, but at the same time. Now that's the most up-to-date, which is now going back many years actually, and I don't know whether that position has changed, but I think this was quite a long period of time during which nobody ran into difficulty.
I think Sue Clark has a real expertise with regard to pouch resections, and again it sort of adds to the portfolio of specializations at St Mark's, where you have a surgeon who not only do you have teams of people who can repair and save people's lives with the pouch operation, but you also have expertise in terms of looking after pouches when they go wrong. And in fact, we had a number of questions earlier in this series to various people about how people get referred to St Mark's, because we have a number of people on this sort of Zoom events who are remote from London, from Yorkshire, from wherever, and they don't necessarily have access to the same extensive support that you get in specialist centres. And that's a key point from the coloproctologist report, of course, as you mentioned. Do you think that as a result of that report and others, that the operation is being focused into specialist centres more now? Is that something that's happening that you see? Or is it still being carried out in a sort of fairly random way by a lot of surgeons who sort of think it would be a good idea to have a go?
No.
And if they are being condensed, is that a good thing or a bad thing for future pouch surgery?
Okay. Well, I mean, I think that's an very important question. I don't know the answer, but I mean, the publicity through the literature with Omar Faiz and his analyses, which he's kindly invited me to join with his team of people working on that sort of question. When that first paper came out about 10 or more years ago, that showed that the majority of pouches done in the country were done by, you might say, the occasional surgeon, and that this seemed to me and to us, the authors, as a sort of scandalous thing, because the patient doesn't know. And so whether, I cannot believe, David, that has not changed, but I don't know, because, I'm not sort of in the field anymore. But coincidental with, over the last 10 years, there has been no doubt that there's a greater accent on IBD specialization in hospital practice, where you, I don't know about regional, but you certainly have IBD units competent to manage at all points of the disease, from medical treatment, surgical, whatever, combined with teaching and training and research. That, and I don't know whether there are how many outliers there are.
Yeah.
Of course, when we did the set up the registry, it was a voluntary thing, so that if you did the odd case, you didn't have to put your patient in and demonstrate. You could just remain under the radar.
Yeah.
I got another view of the situation to some extent as a medical expert in medico-legal work, which I did up for 5 years, up to about 2014, where quite a number of patients, or claimants, as they then suddenly changed from being patients to claimants, that I had to give an opinion on, had been pouch patients who had failed, had been treated in units which basically were doing the occasional operation. And that just mean the occasional surgeon, it means the occasional radiologist, for example. So you send the patient round to the X-ray department for a scan or something, and the radiologist has no experience of what scans look like in disturbed pouches, so they just say something which doesn't raise the warning signs of pending disaster, something like that.
Yeah, I'm staggered and disappointed that the coloproctologist survey has stopped. I think you said that happened 2 years ago. I'm really staggered by that, and I'm going to email you about that separately after this, because it won't be of so much relevance to the rest of the audience.
I added on to the Association of Coloproctology, actually. It was a disappointment.
But I mean, okay, well, I mean, my question is, how do we get information on the population of pouches moving forward? What's happening? How's their quality of life? What problems are arising? These sorts of questions. And the Association of Coloproctologists survey was the best, most thorough survey of outcomes for pouch surgery that I've read anywhere. So separate to that, because we've got other questions to get to, my concern, having heard that, is that survey is not going on. So where do pouches like me and like many others get that information on an ongoing basis about the progression of follow-up on people with pouches? Very important. Whether the 10 or 11% stays the same, or whether it grows.
Exactly.
Whether pouchitis becomes more of a problem. These sorts of issues. And what you need is numbers, like you said about the Mayo Clinic. You need numbers. Everyone's got their own stories and their own journeys and their own experiences, obviously. But that doesn't add up to a body of evidence that gives you the big picture.
No, I like what you're saying. You're going to email me about that, yeah?
Yeah, I'll email about you separately. But just for now, we'll come back to the question. So on the topic of options for people with pouches that aren't performing well, what are the options for people? We know about the reversion to a permanent stoma, but there's a couple of things you mentioned right at the start of your talk about the cock reservoir, and about that coming back into fashion or into vogue. So why is that coming back in, and do you see that as being a viable option for people who these pouches are failing.
Yep.
And then another comment came in from Natalie Walker, which is about the bowel transplant and whether that was an option over having a pouch in the first place. So
Yep.
slightly different questions. Sorry about that.
Yeah, no, okay. Yeah, when somebody's pouch is not, when it is perceived by both the patient and, you know, everybody, that that the patient's condition with a failing pouch is no longer acceptable, then then your options are defunctioning through a normal type of stoma with excision of the pouch, or defunctioning, bringing out an ileostomy, removing the pouch at the same time, bringing out an ileostomy, leaving the pouch, much less traumatic, or some form of, or an ileostomy with removal of the pouch, but in the form of a cock ileostomy. I think those are the surgical options. And perhaps I can just mention bowel transplant. I don't think bowel transplant is a viable thing for in surgical practice. It's largely small bowel transplantation. And I just got to be, I don't quite know actually, David, what what bowel transplantation in this context, what your questioner means by
it was a question from Natalie, bowel transplant over pouch option. So rather than a reversion, it was more about, I got confused there. It was more about in the initial stages, the initial presentation.
Yeah.
Instead of having a pouch, is there an opportunity to have a bowel transplant?
Right. But in a way, you know, if you've got an inflamed colon rectum that needs treatment, you are removing that, and you're using the bowel, which is sitting there above, the small bowel, to make your surgical reconstruction. So you won't be taking somebody else's bowel and putting it into that patient. If you're thinking of, perhaps the question Natalie was wondering, whether if you've got ulcerative colitis, which involves just the colon rectum and the upper part of the anal canal, and you remove that and put a new one in from another patient, or part of a large bowel from another patient, because the patient donating the bowel would need some to continue with. Would that be satisfactory? And the answer to that is that actually the possibility of rejection and complications from the immunosuppressive management that would be required to achieve that, I would suggest far outweigh the ease with which you would be able simply to remove the inflamed colon and rectum and use the patient's own small bowel for the reconstruction. I mean, I don't think anybody, you know, transplantation of intestine, where taking a graft from another patient, is sadly not been as effective as had originally been hoped. And I'm not sure to what extent, even in patients with no small bowel or very little for other reasons, who would have been candidates for a small bowel transplant, what the present situation is with regard to that. I know that a lot of units gave, when they were doing small bowel transplantation, often with liver and pancreas thrown in as well, as it were, would have not continued to do that. And the great Thomas Startzel, who was the transplant surgeon in Pittsburgh, Pennsylvania, who people say nearly got a Nobel Prize for his work, when he retired, I think the small bowel transplantation program, as opposed to the liver or kidney transplantation, lapsed. So, I mean, that's going back a long time as well. But so bowel transplant, I don't think is at all realistic. As far as the resurgence of the cock, if you have a failing ileoanal pouch, the idea is that removing the pouch and replacing the whole arrangement by a continent ileostomy is technically possible. And there are many expert cock pouch surgeons around in the world, particularly in Scandinavia, where it all started. More recently in Germany, where a surgeon from the old East Germany has undertaken the use of the cock in patients with a failing ileoanal. And I indeed was, about 18 months ago, was invited over by Professor Gabriele Möslein to Wuppertal, where she worked at that time. And he came over and he did a couple of these operations, a very beautiful, clean surgeon. And so the argument is that the patient's quality of life can be improved from having a terrible experience with anal function, with a failed pouch, into having adequate management of options with a cock ileostomy. Now, where you've got experts like him, or Helge Meervold, who was a long-standing assistant of Koch, who went back to Norway after he'd done his time in Gothenburg, and continued working with Koch actually from Trondheim, where he became professor. They are saying, or he was saying, as indeed the German guy whose name has slipped me at the moment, that a cock will give a good quality of life. My concern, which may be regarded as outmoded, but my concern is this: that a patient who's failed an ileoanal has sort of been to hell and back, it seems to me. Yeah. And what they need is stability in their life, allowing them, A, to recover their general health, and B, their life's activity, be it family life or social life or indeed professional life. And they don't need to have an operation where there is, a 60%, 40% chance of having to have another operation, and then, another 40% chance of having to have a third operation to revise the valve. Oh. But if people like Meervold and this German surgeon are saying, well, actually, in our hands, we have very low valve failure rates, it does make a difference. But I just sort of felt uneasy because if a cock fails, then the patient's already lost 50 centimeters of small intestine anyway. Yeah. Because they've had the pouch and the bits removed from, so they're down on a total small bowel length. And if a cock fails, you can add another 40 or 50 centimeters, so they're down by a meter out of 5 or so, 4 to 5 meters of small bowel. But it's something that needs to be considered. Yeah. And that also applies to doing an ileostomy above a failing pouch. Yeah. You may not be running in and out of the loo because you no longer have anal function, but you are likely to have a higher ileostomy output per 24 hours than had you, in the first instance, had a conventional proctocolectomy. Oh. So these are dynamic things that go to making one try to advise the patient on the best options.
Yeah, yeah. Okay, absolutely brilliant. Thank you. I think we're going to have to draw this to a close for the sake of time. my apologies if we haven't managed to get to your questions. Before everyone dials off, we are following on this fascinating session with the AGM for the Red Lion Group. So if you're a member of the Red Lion Group, please don't go anywhere because we'd very much like to achieve quorum for our AGM. But for now, and the thank yous are coming in already, may I offer on behalf of all the people who dialed in and many others who weren't able to, my profuse thank yous to Professor John Nicholls for his time and his expertise, as always delivered with great charm from his home and in his retirement. Thank you very much for a fascinating presentation, and also for on behalf of all the patients you've treated over the years, all your kind expertise. I think with you guys, you know, you're the engineers, but you know, the patients, the way you treat the patients has so much of an impact on the patient's experience of the whole journey. And you know, I was treated by Mortensen in my time, but many people, just as with Mortensen, share the same observations with me, that you had a wonderful bedside manner, and it's the way in which people felt that you treated them as people with vast respect that helped them through the journey, and of course all the plumbing and replumbing that you were also expert at doing. So may I add that as a personal comment, but on behalf of everybody, thank you so much for your time today, and we wish you continuing well and good health in your retirement. For everybody, a recording will be on the Red Lion Group website in due course of this presentation. I think we're looking to load it up within the week, and there'll be a notification for that. But for now, for all the members, please stay on. But for now, if we can show our appreciation in the traditional Zoom way for Professor Nicholls' time today. Thank you.
Well, thank you very much, and thank you for your kind words, David. I do appreciate them. It's very kind of you to say what you said. Thank you.
You're welcome. Thank you. Thank you very much. So